Okay, I think we are going to get started right now. So our first speakers today are going to be Katarzyna Klonowska and Elio Adib from the Department of Medicine. So everyone please give them a warm welcome. They are going to be presenting their poster, Phase 2 Clinical Trial of Everolimus for Cancer Patients with Inactivating Mutations in TSC1, TSC2, Genomic Alterations and Response in a Pan-Cancer Cohort. Each poster presenter will get 9 minutes for their presentation, followed by 4 minutes for question and answer. For the Q&A session, you can ask questions via the hand raise feature, but we would prefer if you typed them into the chat feature so that the speakers can see them. So let's give them a warm welcome and they will get started.
All right, thank you everyone for joining us today, and thank you Alexandra for the nice introduction. So my name is Elio, and with the help of my colleague Katarzyna and under the mentorship of our PI, Dr. Kwiatkowski, we will be sharing with you the findings of our most recent work, which is a close collaboration between Dana-Farber Cancer Institute and Memorial Sloan Kettering Cancer Center. And this is a phase 2 clinical trial of Everolimus in tumors with TSC1 and TSC2 mutations. So just to give everyone a quick background about why this work is important. So mutations in TSC1 and TSC2 genes are thought to activate the mTOR pathway. And it's been thought throughout the literature that the use of inhibitors of mTOR, just like Everolimus, will be useful in those patients. Most of the prior reports are just retrospective analyses of clinical outcomes or prospective clinical trials in very specific cancer types. So what we decided to do here is to look at this in a more pan-cancer approach. So just a quick breakdown of the clinical characteristics of the patients. So we enrolled 30 patients at DFCI and Memorial Sloan Kettering. 15 are male and 15 are female. Most of them are of white race. In terms of primary cancer sites, the most common were bladder and uterus. Most of the patients had really good ECOG performance status at the time of enrollment. I will skip the mutation part because my colleague is going to touch upon that in more detail in upcoming slides. But in terms of response, unfortunately, we had only 2 patients who had partial response to Everolimus, and 2 more that had what we called clinical benefit. And the way clinical benefit was defined is stable disease on treatment that's extending beyond 22 weeks of treatment with at least some degree of tumor shrinkage. So overall, we had 4 patients that had good response to Everolimus out of the 30 patients. In terms of adverse events that occurred on the drug, the most common single adverse event was mucositis. And it occurred in about 27% of the patients. And this is a really well-defined and well-studied adverse event that occurs with mTOR inhibition. Unfortunately, we had quite a few patients who had grade 3 or more adverse events due to treatment. And again, unfortunately, one of the patients actually passed away due to drug-induced pneumonitis. So this is one of the 2 patients reported here. In terms of the outcome, so what you see in panel A is just, again, a breakdown of the patients based on their primary cancer sites. As we said, the most common were bladder and uterus. In terms of response, moving to panel B, this is what we call a waterfall plot that's showing the response of all patients. And what you see on the y-axis is the change in tumor size compared to the baseline. So as you move towards the right-hand side, those would be the patients that had the most reduction in tumor size on treatment. So the last 2 in green right here are the patients that had partial response on Everolimus, whereas the others had either stable disease in red or progressive disease in blue. What we're seeing in panel C is just a closer look at the 4 patients that had either partial response to Everolimus or clinical benefit, the way it was defined before. And those are those 4 patients. 2 of those had uterine leiomyosarcoma as a primary tumor site. Those are patients 3 and 21. 1 patient had upper tract urothelial carcinoma. This is a patient in green. And 1 had anal squamous cell carcinoma. On the right-hand side here is just another way of looking at the same results while looking at the change in the tumor diameter throughout the different times of assessment for these patients. As you can see, even though we had 4 patients who had either response or clinical benefit, only one of them actually had a durable response to everolimus extending way beyond 24 months of treatment. In terms of progression-free and overall survival, those were around 2 and 7 months on median. Kasha, you can take it from here.
Thank you. We performed genomic profiling for all 30 patients in this trial. Our first approach at study entry was a next-generation sequencing analysis of several hundred of candidate cancer genes. In addition, we performed whole exome sequencing, in other words, sequencing of all genes in human genome. Here in panel A, we have summarized the spectrum of pathogenic somatic variants in either TSC1 or TSC2 sequence. This kind of graphical representation is often referred to as lollipop plot. Each of the lollipops represent one mutation. They are colored according to the mutation types. As indicated in panel B, the vast majority of the TSC1 and TSC2 mutations that we have identified are small mutations, either SNVs or indels. In addition, we have identified 2 large deletions indicated here in orange. These were multi-exonic deletions encompassing TSC2 gene sequence. In our cohort, there were 2 good responders with TSC2 mutations and 2 good responders with TSC1 mutations, indicating that either of these genes or mutations in these genes could be associated with good response to everolimus. Next. In our cohort, the spectrum of mutations and the number of mutations per analyzed cancer sample was very different and variable, both in groups with good clinical response and without clinical response. So there was no clear association between the number of mutations per sample and response to everolimus therapy. In the commutation plot on the right-hand side, we have summarized our mutational findings from whole exome sequencing analysis. Such plot facilitates the interpretation and assessment of potential association of genomic findings with response to therapy, in our case, everolimus. Each column corresponds to 1 patient in the study. In the top row, indicated as clinical benefit, we indicated with green those patients who had good clinical response, and those without clinical response are indicated in gray. In rows below, we have included the information about the response, gender, cancer type, and age. Below, there is a summary of mutational findings for all genes that were mutated in at least 10% of the entire cohort in this study. In addition to TSC1 and TSC2 genes, the TP53 was a frequently mutated gene. However, mutations in TP53 did not correlate with a response in this study. Among our 4 good responders, 2 had uterine leiomyosarcoma, as Elio has already mentioned. Interestingly, both of them had concurrent mutations in both TSC1 and NF1 genes. In addition, one of these patients had features of perivascular epithelioid cell tumor, in short, PEComa tumor. Our findings indicate that both concurrent TSC2 and NF1 mutations and PEComa features may be related to favorable response to everolimus. We would like to thank all patients, clinicians, and researchers involved in this clinical trial. It was possible thanks to close collaboration with Dana-Farber Cancer Institute in Boston and Memorial Sloan Kettering Cancer Center, and was funded by Novartis. Thank you so much for your attention.
Thank you for that. So we are going to start the question and answer portion. If anyone has questions, they can either use the hand raise feature in Zoom or send them through the chat feature in Zoom, or there is also a chat feature if you still have the Discover Brigham website open on your screen. Okay, so thank you, Dr. Klonowska and Dr. Adib, for that great presentation. We're now going to have a quick 1-minute break before transitioning to our next presentation. So I'm going to have presenter number 2 get ready, and in 1 minute or 2, we will get that started. Okay, it looks like we are ready to get started. So I would now like to welcome our next poster winner, Ming Liu from the Department of Pathology. He will be presenting his poster, Deep Learning-Based Computational Pathology Predicts Origins for Cancers of Unknown Primary. Again, he will do a 9-minute presentation followed by a 4-minute question and answer session. And again, you can use the hand raise feature for the Q&A, or you can type questions into either chat feature. So we are going to have Ming Yang get started.
Thank you for the introduction. Hi everyone, my name is Max, and the topic of my research today is using computational pathology to predict the origins for cancers of unknown primary. So just a very brief background on the topic. CUP broadly categorizes cancers where a primary origin cannot be determined, which represents about 1 to 3% of all cancers. And these patients tend to have very poor survival outcomes. And many people agree today that identifying the primary tumor and providing site-specific treatment will tend to lead to improved patient outcomes. And this is currently an active area of research. So when patients are diagnosed with a CUP, they typically undergo an extensive workup in hopes of identifying the origin. And this could be a very time-consuming and resource-intensive process, and is not always successful. So this process can occur at the expense of treating the patient in a timely manner, which is why, in light of this, there has been a handful of recent studies based on molecular signatures where they're trying to predict the origin based on genomics. But the motivation of my research presentation is that routine histology slides are more widely available throughout hospitals, and using this kind of a prediction approach based on histology would also appeal to low resource settings. So I'm going to briefly go over our study design. So we train a deep learning classifier based on a large data set of H&E primary and metastatic slides, for which we already know the ground truth primary site. We then evaluate our model on a held out test set of metastatic and primary tumors, again of known primary, as well as an external test set that were submitted from a wide range of different hospitals in the US and internationally. And lastly, we have a database of over 700 cases that were assigned CUP. And by using their electronic medical records, we were able to identify around 315 cases assigned a primary differential by experts at the Brigham. And we assessed the agreement between the model's prediction and the primary differential assigned for these subset of CUP cases. So just to summarize, we have a total of 32,537 H&E slides, part of which came from NIH consortia such as the TCGA and CPTAC, and the remaining are from in-house databases between over the last 15 years. And there are in total of around 25,000 primary tumors and around 7,000 metastatic tumors that were grouped into 18 different primary origins. So the dataset was shown here was split into training, validation, and testing. So if we focus on the test proportion of the dataset, we have around 6,500 slides, of which about 5,000 are primary and about 1,400 are metastatic tumors. So without going into too many technical details, we use a weakly supervised learning approach that is capable of learning directly from the slide level labels. So much of the code we used for this project were from one of our previous works and is publicly available using the links shown below. And a model uses attention to automatically learn which regions of the slide have high diagnostic relevance and which regions can be ignored for prediction purposes. And the network will learn to predict both the primary origin as well as whether the specimen is metastatic or primary. So shown here by the two different network branches that perform the two separate tasks. And we provide the patient's gender information to the model in addition to the H&E slide itself, because some primary origins are gender specific. So in terms of results, here's the model's confusion matrix, where the diagonal entries represent the fraction of cases predicted correctly for each origin. So we can see that in general, it works pretty well for most classes, and the overall accuracy of the model on a test set is around 83%. Which is decent. But instead of just looking at the top one accuracy, if we consider also the model's top 3 and top 5 predictions and see how often they overlap with the ground truth, you can see the performance is actually quite impressive. For example, the top 3 accuracy is over 95% in this case. And sort of a comparable performance was also achieved on our external test set. So below on the left, we also show that by binning the model's predictions into different bins in terms of the model's confidence and evaluating the accuracy for each one of those bins, you can see that more confident predictions are associated with higher accuracy. And on the right, if we look at model's predictions across all 18 different classes, we can see that a significant proportion of the predictions are actually correctly classified with high confidence. So the implications of these results are: one, if you don't just consider the model's top 1 prediction, but also its top 3 and top 5 predictions, then you have a high chance that the true origin would be captured in one of them. And also, if you see the model's prediction has a fairly high confidence value, then there's also a higher probability of it being accurate. Next, just briefly, we're going to look at the accuracy of the model in terms of its ability to predict primary versus metastatic tumors. So the accuracy of the model for that second task is around 85%. And if we look at several tissue sites where you might frequently encounter both primary and metastatic tumors, as shown here, we can see that the ROC AUC is hovering close to 0.8 or above for all of them. So next, we looked at a little more closely the model's performance on just the metastatic tumors of our test set. So since some metastatic tumors will be more easily diagnosed than others, we also looked at we looked at the performance for various subsets of the cases based on, for example, the number of diagnostic IHCs used, shown in the middle portion of the table here, as well as whether the case required clinical correlation or radiologic correlation, and whether it is poorly differentiated, sort of using these as different proxies for how difficult these cases are. So we can see for the most part that we get performance that's comparable to previously reported on the entire data set of primary metastatic tumors. And we also notice a similar trend with the top 1 and top 3 accuracy throughout this table. So lastly, we looked at our CUP test set, and we saw that the agreement between the model and the primary differentials assigned by the physician was around 61%. And similarly, the agreement is more substantial when we consider the top 3 agreement and the top 5 predictions, as well as when the models is more confidence. For example, if you look at predictions made with a confidence value of greater than 0.9, then you're going to find a much larger agreement within those subset of cases. So one additional thing to note is that the model also provides a nice simple way of interpretability, where you can overlay the model's attention with the whole slide image itself and look at which regions the model thinks have high predicted relevance and that the model attends to for making its predictions, which are shown in red. And shown in the right are these high attention regions that are picked out by the model for each case. So here we visualize the attention heat maps for breast and colon cancer metastasizing to different parts of the body. And we verify that the model is indeed focusing on the tumor regions for this predictive purposes. And tying all this together, we have a relatively crude website demo for one possible way of making this tool available or useful for clinicians, which we can display for each case. The model's top predictions is associated with confidence, as well as displaying the whole slide level H&E image, as well as the overlaid heat map for its predictions. So physicians could verify that the model is not basing its predictions on anything unexpected or erroneous. So lastly, in terms of clinical utility, this is still very much just a proof of concept, but we understand that the entire differential diagnostic process is very complex and requires reasoning and consideration from multiple sources of data, as well as backed by medical expertise and experience. So as we also saw, the model's top one accuracy is in fact around 80%. So it might find direct utility in low resource settings where there is simply no pathology expertise available and other means of diagnostic techniques such as IC testing and molecular testing are limited. However, in more advanced clinical settings, a much more appropriate use case would probably be to interpret the model's top 3 or 5 predictions as differentials and combine the model's predictions with the pathologist's expertise in IHC testing to make it faster and potentially more accurate diagnosis. So given a simplistic but real example, here's a CUP case in the database where the physician will look at the clinical history, the histology sample, and then order IC test and arrive at Mullerian origin for the preferred primary differential for this case. And similarly, using our model, you can get the top 3 predictions and see that the model is actually quite confident that should be ovarian, as shown here. But just to rule out the other possibilities, the pathologist may order additional IHC tests and potentially referring back to the clinical history of the patient as well and check the high attention regions picked by the model, just so that we can verify that this reaches the same conclusion as previously, but potentially much faster and using less resources. So that concludes my presentation, and just a big thanks to the authors on the presentation as well as any other members in the lab. And we're also actively hiring postdocs or internship positions. So if you're interested, please feel free to reach out to us. Thank you.
Thank you for that presentation. So we are going to have up to 4 minutes for question and answer. Again, you can use the hand raise feature, or you can send questions through the chat feature in Zoom or the chat feature in the Discover Brigham website page for this presentation. Does anyone have any questions? Okay, it looks like we don't have any questions. So thank you, Max, for that presentation. We're going to do a quick, about 1 minute break before moving on to our next presenter. I think we're ready to get going. So I would like to welcome our final poster winner, David Dan Nugent, MPH, from the Department of Surgery. He will be presenting on the effect of Medicaid expansion on racial ethnic disparities in receipt of definitive treatment and time to treatment initiation, a patient level and facility level analysis of breast, colon, lung, and prostate cancer. Again, he will have 9 minutes to present, followed by 4 minutes for question and answer.
All right, thank you so much for that introduction. So yes, my name is David Dan. I am a research fellow at the Center for Surgery and Public Health at the Brigham and Women's Hospital, and I am also a medical student at McGill University. I would like to thank Discover Brigham for the opportunity to present our work looking at access to cancer care for minorities following Medicaid expansion. I have no relevant conflicts. So here's a brief outline of the presentation, and we'll start with some background. So many of you are aware that racial ethnic disparities in health outcomes exist in the United States, and this is no different for cancer. Over the last 2 decades, race-based disparities in cancer outcomes have persisted in the United States, with Black men and women having higher cancer-specific mortality rates regardless of disease stage. Researchers, including researchers from our group, have attributed these disparities to systemic inequities in the way cancer care is delivered. For example, we showed that minorities are less likely to receive definitive treatment for a number of cancers, including prostate cancer. One of the ways to tackle racial ethnic disparities in health outcomes or in cancer outcomes in the United States is to target specific hospitals that serve a large proportion of minorities. These hospitals that serve, again, a large proportion of racial ethnic minorities are called in academia minority serving hospitals. And the idea is that if we can target interventions at these few minority serving hospitals, we could potentially significantly reduce national disparities. Moving on now to Medicaid expansion under the Affordable Care Act. Medicaid expansion or coverage expansion is another way to tackle racial ethnic disparities. Medicaid expansion specifically, for those who are not aware, was one of the provisions of the Affordable Care Act. Participating states asynchronously expanded Medicaid eligibility to non-elderly and low-income adults. the expansion was successful in reducing uninsurance rates and narrowing coverage disparities across racial ethnic groups. This resulted, for example, in earlier stage cancer diagnosis, probably due to improved access to primary care and better screening access, as well as some improvement at the site of care level. So some hospitals, as a result of improved coverage, demonstrated improved quality in the care they provided. So our objective is to take these two ideas and see how they relate to each other. So we want to understand if Medicaid expansion under the Affordable Care Act was associated with improved access to definitive cancer therapy for minority cancer patients and for patients treated at minority-serving hospitals. In other words, we want to understand if expanding coverage under the ACA improved and helped the individual patient access care, and how did that impact care at the facility level at minority-serving hospitals. In terms of methodology, we use the National Cancer Database, the NCDB. It is a national clinical oncology registry. It collects data from over 1,500 Commission on Cancer accredited facilities. The NCDB captures roughly 50% of all prostate cancers, 80% of all lung cancers, 60% of all colon, and 65% of all breast cancers diagnosed in the United States. In terms of patient selection, we selected a cohort of patients that had either prostate, lung, breast, or colon cancer, and that were at stages, so cancer stages, eligible for definitive treatment per NCCN guidelines. In other words, these patients, if we treat them with either surgery or radiation therapy, for example, would see significant clinical benefits. We excluded patients under the age of 40 because we do not have Medicaid expansion information for these patients. And we also excluded patients on Medicare, so those 65 and over. We also excluded patients that received treatment more than a year after diagnosis and those that were missing follow-up data. We define minorities as non-Hispanic Black and Hispanic cancer patients. And so that our minority serving hospital definition is concordant with the minority definition, we identified minority serving hospitals as hospitals in the highest decile in terms of the proportion of cancer patients who are non-Hispanic Black or Hispanic. In other words, if they're not in the top decile of treating non-Hispanic Black or Hispanic patients, you are considered a non-minority serving hospital. And this is simply following what has been published in the literature, notably by Ashish Jha and al. In terms of study endpoints, we looked at rates of definitive treatments, rate of time to treatment initiation within 30 days, and treatment within 90 days. Receipt of definitive therapy in the context of localized cancer disease is an important measure of access and quality of cancer care, considering that at diagnosis, a majority of these tumors that we're looking at are treatable, and if we treat them in sooner rather than later, it's often associated with improved survival. And again, as a reminder, our cohort of patients in an ideal world would all be treated sooner rather than later because they are at stages eligible for curative treatment. In terms of study design, we use a difference in differences approach. To simplify kind of the idea, we took expansion states and non-Medicaid expansion states, compared how these outcomes changed for them before and after Medicaid expansion, and tried to isolate the true effect of Medicaid expansion under the Affordable Care Act. You could kind of imagine this as a before and after study, but with a control arm, so that we can actually isolate the true effect and remove any externalities. In terms of results, we found that compared to patients and facilities in non-expansion states, patients in Medicaid expansion states, and specifically racial ethnic minorities, had a higher rate of treatment within 30 days compared to before Medicaid expansion, but not within 90 days. And there was no difference in receipt of definitive treatment. In other words, the quality of the care that was provided was the same, but we were providing that care a bit earlier than before. At the facility level, so when we look at minority serving hospitals, we see no difference in time to treatment initiation, may it be in 30 or 90 days, and no difference in receipt of definitive treatment, again, at the facility level. So no changes whatsoever for minority serving hospitals. Our study has a number of policy implications that can be classified, I guess, into two big umbrellas. The first one is that improved coverage partially improved access to cancer care for racial ethnic minority patients. Similarly to what has been published in the literature, we show some improvement in the quality of the care provided following Medicaid expansion, following better access to insurance for low-income populations and racial ethnic minorities, for example. However, it is obviously important to understand that insurance is only one aspect of care delivery, and we need much more processes to be accomplished before seeing significant improvements. The second kind of big takeaway from this study, and the first kind of preliminary takeaway that we were able to generate in the literature, is that indirect funding of minority serving hospitals via improved coverage of their patient population did not impact the quality of care. This is especially relevant considering that minority serving hospitals, as shown again in the literature, faced one major challenge, and that challenge is access to funding. And one way we can improve the funding of minority serving hospitals is to improve, for example, the coverage of their patient population. We showed, however, that simply improving coverage of their patient population isn't enough, and instead directly targeting their needs and directly funding these hospitals might have a bigger impact. One image I always like to show at the end of these presentations on access to care is the voltage drop model by Eisenberg and Power. As you can see, insurance availability, enrollment in insurance are only the first and second steps that are needed to deliver high quality care. There are a number of things that we need to do to achieve that. And our study shows that steps 1 and 2 do have improvements for the patient, but many more endeavors are needed to improve care. Thank you.
Okay, we're now going to open the floor for the question and answer session. Again, you can raise your hand in Zoom, or you can use the chat feature in Zoom or the chat feature on the Discover Brigham page for this event.
Great. So I see a question from Dr. Adib. He says, did you look at the differences by cancer type? Thank you, Dr. Adib. That's a great question. We did look at differences by cancer type. Obviously, as many of you know, prostate cancer is an indolent disease when localized, obviously, and early treatment is not necessarily associated with better survival. We, again, removed low-risk prostate cancer patients and look at intermediate and high-risk prostate cancer patients separately from all of the other cancers. And we did see that for all of the other cancers, there was much more improvement in the time to treatment than in prostate cancer, which is obviously somewhat expected, because even if you have better access to prostate cancer care, even if you're intermediate or high risk, there isn't necessarily such an impetus to treat you quickly compared to obviously higher stage breast, colon, or lung cancer.
Do we have any other questions? I don't think so. Okay, so that concludes our session. I would like to thank Dr. Nugent for his presentation, as well as all of our poster presentation winners who went today. And I would like to thank all of our attendees for attending this session. And you can check back on the Discover Brigham website for the schedule and agenda for the rest of the day today. Thank you.